Welcome. In this session, we're going to cover an overview of population health management. In the upcoming weeks, we'll go into more detail in each of the segments that we cover in this session. But for this one, we'll provide a high-level overview of how everything in population health management fits together across the clinical and administrative functions. So to start, let's talk a little bit about why population health. Why are we actually doing this? And I think the best way to start is actually with a patient story. So I'm sure most of you know a Fred. And Fred costs $25,000 for the healthcare system. And he's 15% of the population, 60% of the total cost, and the failure of fee-for-service sick care. But as Dr. Paul Batalden said, every system is perfectly designed to get the results that it gets. Every system is perfectly designed to get the results that it gets. And U.S. healthcare is no exception. U.S. healthcare is perfectly designed to get the results that it gets, which is inadequate care for people like Fred. And, as was shown through some recent data on comparing OECD countries with regard to various aspects of health outcomes, the U.S. doesn't rank very well across the board. The U.S. ranks 5th in overall quality of care, 9th in access, and 11th out of 11 in efficiency, equity, and overall healthy lives. And all of that while having the highest expenditure on a per capita basis of OECD countries. So again, this isn't any individual clinician's fault. This isn't Fred's fault. This is the system's fault. And our system is architected in a way that it's perfectly designed to drive these sorts of outcomes. So that's the kind of clear explanation of why population health in terms of the emotional side of it, which is because we ought to. But there's also a rational side to it. Healthcare demand is rising. Projected per capita medical expenditures continue to grow at about 6.5% annually. Despite some curbing of that trend in recent years, it's actually spiked back up to 6 to 7% on an annual basis. This demand is being driven by the aging population, by an increasingly unhealthy population, by general medical inflation, by medical technology increases, and a variety of other factors. So over the past 30 years, that 6.5% growth has been unsustainable for the industry. Meanwhile, the funds that are available to actually pay for this care are declining. Currently, commercial payers pay 1.5 to 2 times as much for the same services as Medicare or Medicaid. That cost shift has been increasing every year, and that cost shift is now unsustainable. Employers are dropping coverage because healthcare has become too expensive. Medicare is quite literally running out of money. In 2014, Medicare took in exactly as much money in the Part A trust fund, which is how healthcare hospital expenditures are funded by Medicare, took in exactly as much money as it paid out. Every year before that, since the inception of Medicare, the Medicare Part A trust fund took in more money through payroll taxes than it paid out. And every year since 2014, it's paid out more money than it's taken in. So depending on the projections that you believe, Medicare Part A, which is how hospitals are paid, will actually run out of money at some point in the 2020s. Now, of course, what the government will do is increase taxes to relieve that, or shift deficit funding to cover it from other sources, but that places an even greater stress on the overall economy. State budgets are running out of money for Medicaid. Fewer taxpayers are available to pay into these programs in line with the aging population. So as less and less of the workforce, less and less of the population is in the active workforce and more people are on Medicare, there are fewer people paying in and more people withdrawing. And in addition, as I mentioned before, the deficit in debt spending to fund all of these healthcare expenditures is continuing to grow. To put a finer point on it, these shifts in coverage, as I mentioned with the aging demographics, are really exacerbating the situation. So in 2008, 56% of the population was commercially insured, 15% in Medicare, 14% in Medicaid, and then the remaining 15% were uninsured. As we fast forward to 2035, due to healthcare reform and the aging population, 55% will be commercially insured, and the portion on Medicare and Medicaid will continue to grow. But the utilization profile looks different because the older populations and the poorer populations access care with higher frequency than the wealthier commercially insured populations. So if you look at the utilization that's covered by government payers, it'll increase from 43%, the combination of Medicare and Medicaid in 2008, to 51% as that combination in 2035. But then we talked about the cost shift, where commercial payers pay more than their fair share for every service that they pay for. So the spend on the commercial side is going to continue to get squeezed as the population that draws on Medicare and Medicaid continues to grow. So if you line up all of these elements and combine it with the 6.5% growth in healthcare costs, along with the 4.5% growth in GDP, and the fact that we're currently at about 19% of GDP going to healthcare costs, if we say Medicare needs to be limited to its current level as a percentage of GDP without increased taxes, which is what would be required for the Part A trust fund to maintain its sustainability, then overall healthcare expenditures have to fall to about 14% of GDP for affordability and long-term sustainability. So this isn't just an aspiration in terms of changing the way care is delivered. The healthcare industry, because it's predominantly funded by the government or by employers through payroll withholds, is quite literally running out of money. And so to get from the 19% to the 14%, somehow we have to take out over 20% of healthcare spend on an inflation-adjusted basis, and we need to reduce the trend 2%, from 6.5%, which is what healthcare expenditures grow at today, to 4.5%, which is what GDP grows at. So those two shifts, that reduction in overall spend, as well as the change in trend, means that the dollars have to come out of the system in some way or another. So under the fee-for-service model, there are two different levers that can reduce this cost. One is reimbursement compression. So simple economics, price times volume equals total cost. So this is reducing price. Commercial insurers are already becoming more aggressive with provider reimbursement. They've had additional Medicare Advantage rate cuts, which have caused a decline in their Medicare Advantage reimbursement, and various departments of insurance are limiting rate increases in commercial products, which further compresses the reimbursement. Medicare is limiting overall reimbursement in order to prolong their solvency so that they can last past the 2020s and the Part A trust fund doesn't go bankrupt. And many state Medicaid programs have ceased year-over-year adjustments entirely. So paying exactly the same in one year as was paid in the prior year for the same services, while the underlying costs continue to increase. So that's reducing price, reducing the reimbursement. The other option is to reduce volume. So that's reducing avoidable utilization. Some of that is already happening. There's been focus on reducing unnecessary testing, use of expensive sites of service, lack of informed consent, where patients have procedures done where a conservative care pathway might be more appropriate, or more expensive treatments that don't have higher efficacy that's been proven. So there have been some efforts to limit that, largely driven by payers inserting utilization management protocols that actually, unfortunately, end up causing additional administrative burden for both the provider and the payer. Those prior authorizations, step treatments, denials, redirections of care are the traditional levers that are used to do this. But there are also other approaches around care management and overall population health management efforts, which we'll talk about shortly, that are being increased to reduce this volume. But the intersection of both of these is actually required to change the cost trend. So if we cut the price growth, if we cut prices, and allow volume to grow unchecked, which is what's happening to some extent in the current fee-for-service system. The payers are trying to reduce reimbursement, but the providers, because they have the supply of the services needed to deliver the care, are continuing to deliver more and more care. It's kind of the if you build it, they will come model of healthcare. And there are plenty of examples of how this has happened across the country. One of the most famous ones is using a wide range of data on urology. Researchers showed that across different geographies, on a risk-adjusted population basis, in terms of what needs would be, what clinical needs there are for urological services, despite variation in the number of urologists available in a given community, twofold variation in some cases, the take-home income of urologists was exactly the same. Meaning that in those markets where there were twice as many urologists, there were actually twice as many procedures occurring relative to the population. So the same thing plays out with hospital beds. Admissions per 1,000 are higher in New York. In Manhattan, there are 6 beds per 1,000 people, and the admits per 1,000 are significantly higher. Across the country, there are 2.8 beds per 1,000 people, and the admits per 1,000 are much lower in other markets. In the Kaiser system, the beds per 1,000 are 0.8, and their admits per 1,000 are even lower. So, unfortunately, when the supply exists, it creates demand for additional volume. If we try to reduce the volume without addressing the price part of the equation, through better health management or through more of the blunt force tools of utilization management, the negotiating power may still stay with the providers, and what they'll do is use that to drive up price so that they can meet their bottom line and their cost structure. So what's really needed is a combination of reducing costs through better health management that reduces volume, along with a reduction in the underlying costs of delivering the care, so that we can reduce the unit price and mitigate the cost trend at the same time. For this, providers need to actually own the cost equation, because if they don't, all of this is just being done to them rather than being done by them. So to that point, why population health? Because we must. We have to. Otherwise, the economic underpinnings of the healthcare industry will remain unsustainable, and we won't be able to actually balance the cost equation necessary to allow for continued investment in other sectors, in other industries, that drive sustained economic growth. And fee-for-service providers are very much caught in the middle. If they don't actually embrace the changes and take on risk, and we'll talk about exactly what that means shortly, but if they don't actually do that, then it will be payers and the government doing it to them through reductions in care that aren't being driven by the provider actually better managing the health of the patient, or reductions in price that are being unilaterally dictated by the government or by the payers. And then, perhaps most importantly, population health actually works. There are organizations that have successfully deployed population health management models across various markets. A few examples. South Central Foundation in Alaska, after they implemented a different model of care and a different operating model across their population, drove a 50% drop in urgent care and ER utilization, a 40% drop in hospital admissions, all while having patient and staff satisfaction over 90%. They re-engineered the entire clinical model, from the ambulatory setting to the hospital setting and everything in between, in order to drive these outcomes. CareMore, it's an organization that was recently acquired by a large national health insurer, but was started over 20 years ago by a group of physicians who really wanted to take care of the sickest of the sick in the Medicare population in a different way. They operated at a 67% medical loss ratio. And we'll go more into health plan economics in a future session. But a medical loss ratio is an indication of, at a certain revenue amount, how much of the spend, how much of the premium dollar is spent on medical costs. And the lower that is, the indication is that if the medical loss ratio is very low, there's less unnecessary care happening because there are fewer hospitalizations, fewer unnecessary procedures, fewer readmissions, fewer complications. A 67% medical loss ratio is about 20% lower than average. So CareMore was able to do this, as indicated in the second statistic here, by driving 42% lower bed days per thousand than the Medicare average benchmark. And this wasn't denying care. They drove this while having significantly better outcomes across every clinical category that you could think of. 56% lower admissions for heart failure, 80% lower diabetic amputation rate, 60% lower fall and hip fracture rate. And they did this by investing in everything necessary to keep patients healthy. For heart failure, they had an intensive remote monitoring program. They would provide free transportation for patients to get care in the ambulatory setting if they were starting to move towards an indication of an upcoming admission. For diabetes, they trained all of their clinical staff in wound care so that patients got exceptional wound care at every point in the process, so that it wasn't just referred out to an outside wound care agency, and that's how they drove the lower amputation rate. For fall risk prevention, they actually provide free strength training to all the seniors. CareMore members who are classified as frail elders have 100% greater muscle mass and strength than the average population who has the same clinical conditions, because they actually prescribe the fitness training, have an adjacent gym with low-impact pneumatic weights that they use to help the patients build muscle mass. They'll also go into the home and do home modification, rip up the shag carpets and put in low-pile carpets so that people aren't tripping, put in grip bars. All of that's kind of outside the traditional healthcare environment, but has an impact on healthcare costs. So because their economic model was aligned around driving better outcomes, they actually invested over a 20-year period in a clinical model that supported that. Iora Health is another example. They started with health centers that were focused on union populations for Taft-Hartley funds that paid for healthcare for their union members. And with their first clinic, they drove a 41% lower admission rate, 48% fewer ED visits, and 93% net patient satisfaction. So this indicates that we actually don't have an innovation problem in healthcare. There's been plenty of innovation on what can help drive success in a population health model. What we have is a diffusion problem. And through this course, what we're going to cover is the structural elements of why that diffusion problem exists, as well as what we can do to actually drive change at scale. One of the challenges with these three organizations is they're all small. They've only done it in a couple of different markets. Together, they serve only a few 100,000 patients nationally. So why population health? Because we can. Because it's possible.